Thank you. And then went back to the UK in 2005, did a fellowship in pelvic trauma at Bristol, and then was a consultant in London at St George's for 10 years. All my private practice in London was at King Edward VII. They're both very slightly interesting hospitals. St George's is quite an old hospital. This was in 1750. This is it now, which is now a hotel in the swanky part of London. Unfortunately, it now looks like that because they rebuilt it on the outskirts. But it's sort of known in this country because it's the hospital where 24 hours in A&E or 24 hours in ED is based. And so anyone that can't get enough work at work and watches this at home will see a lot of my old colleagues on the telly. King Edward VII, where my private work was, is most known for the fact that it's where the royal family goes. And so you see the Queen every now and again hopping up and down the stairs. The single best thing about working there was having an office in this building and a parking space in that little mews behind it. So I got a free parking space in central London, which is like gold. So that was a great place to work. But after 10 years, I'd had enough of living in central London. And so for family reasons, predominantly, we came back to Adelaide and started work at the Royal Adelaide. So currently, I'm sort of head of unit and director of orthopedic trauma at the RA. I do most of the pelvic and acetabular fractures and pick up a lot of the complex trauma, which means I get a lot of the groin pain and weird pelvic stuff. I do a lot of hip replacements, hip arthroscopy, and sort of the gamut of knee surgery as well. But I'm up until recently have been predominantly university-based, and so we have a fairly big research team, and there's quite a lot of that going on. So I have a very odd life. I spend probably most of my time proportionately doing hip and knee surgery, but I do a lot of trauma surgery, pelvic trauma, and a fair bit of research as well. So tonight's about common fractures and what's new and what isn't. And I sort of made a list of fractures that I thought we should talk about. So there's a little list there. And then at the end, particularly for the people in South Australia, I just want to cover a little bit about a new fracture clinic that we've set up. So to start with ankle fractures, what's new? Not much is the answer, other than a couple of things. So hindfoot nails are pretty new and flexible syndesmosis fixation. But ankle fracture is pretty common, and there are different ways of thinking about ankle fractures. The typical way is it 1, 2, or 3 malleoli? So you hear people talk about a bimalleolar fracture, a trimalleolar fracture, and people talk about whether A, B, or C, so A being low, B comes through the syndesmosis, C is above. And the importance of this is just the likelihood of the syndesmosis being ruptured. As an orthopedic surgeon, I think it's more important really to look at whether or not a fracture is displaced and whether it's ever been dislocated. Because in terms of treatment and prognosis and what we're going to do with them, the key question is that fracture stable or unstable? Because if it's relatively undisplaced and it's stable, then it almost certainly doesn't need any attention other than symptomatic. Whereas if it's displaced or it's undisplaced but unstable, then it probably needs fixing. So the issues that we're thinking about is really all about the stability of the joint. The most common one is the isolated lateral malleolus, and if it's undisplaced, it's probably stable. But the difficulty is what's displaced and where are we talking about displacement from? Because when you see a report that says there is a lateral malleolus fracture and it is displaced by 2 millimeters, is that important? And it rarely does the report actually say where the displacement's from. So we look at this X-ray here, this is displaced probably by about 3 millimeters at the fracture site. The syndesmosis is untouched. The ankle joint looks fine. So it's a relatively safe assumption that the ligaments down here that bind the fibula down to the rest of the foot are intact, and this is rotated around and it's rotated out. So is that stable or unstable? I don't know. It depends a lot, I think, on the medial side. So if on the medial side of this ankle, there is no swelling and no tenderness, that fracture is probably stable and you can probably not worry about it. A fracture like this is completely undisplaced. So the report of this will say, well, there's 1 millimeter of displacement here. But if you look at this on the other side, there's a huge amount of swelling on that medial side. And they're probably very tender on the medial side, suggesting they've probably got a medial ligament injury. So that fracture might be unstable. So it's really hard to know, even with a good X-ray report, a simple fracture, whether or not it's really stable. And I think the key for me is if it's isolated, if it's one side, so it's just lateral, and they haven't got a big swollen medial side, they're not bruised, they're not tender on the medial side, it's probably stable. And so for those, even if they come to fracture clinic and I'm not sure, we simply give them a boot and say, off you go, walk on it, see how you get on, and then x-ray them a week later. And if they're unstable, when you get an x-ray a week later, it will have shifted. And if it shifted, you've got your answer, it's unstable, it needs operating on. If you see them a week later and it hasn't shifted, then they're probably fine and you can leave them in the boot and just let them go. So I think for a lot of these, that's our plan, boot and fully weight bear, x-ray them a week. And then if they pass the 1 week test, I tend to leave them in the boot for anywhere between 4 and 6 weeks. It's really symptomatic treatment only. I reckon a lot of them come out of the boot much earlier than that, and then they put it back on the day they come and see me. The role of physiotherapy for this group is interesting. The evidence pretty much says that the outcome is exactly the same for this group, whether they have physio or not. It's probably as useful simply to give them a sheet with some physio exercises, but I think the group that see a physio get there slightly quicker. So if they're in a rush, they're really keen, they've got the time, they can go and see a physio, they might get there quicker, but they all eventually end up at the same place. Now you do get surprises. This is a fracture that was referred to me a couple of weeks ago. Looks very straightforward. You can see almost undisplaced here, but the syndesmosis, the gap here between the tibia and the fibula, just looks a fraction wide, and it does here as well. And the report said virtually undisplaced fracture, but there's a hint of syndesmosis widening. And actually, there's a tiny, tiny posterior malleolar fracture here that the radiologist didn't pick up on. But that tells me that the syndesmosis is ruptured, because that's a pull-off fracture from here, and it's where the inferior posterior tib-fib ligaments come from. So that syndesmosis is ruptured. So even though it looks fine, it needs fixing. But the key to this is it was a relatively high energy injury. It was hugely bruised and swollen, and you kind of know that something else has gone on. So that gets fixed. The syndesmosis fixation, in the old days, so when I was training for sure, all syndesmosis fixation was 2 screws, and with or without a plate. And then you came back typically somewhere between 2 and 3 months and took the screws back out. Now we have tight ropes, so running from here to here, these are 2 little discs, and there's a bit of string effectively that runs from there to there, which sort of does the same job, but it allows a little bit of rotation. And the theory is that firstly, if the fibula is not perfectly reduced, it allows a bit of movement and it might get back to where it's supposed to be. But it also means that you can take out this screw earlier. So we can take out this screw at 6 weeks and leave the bit of string behind, and you still got some flexible fixation. So more of the syndesmotic injuries that we're not quite sure, we just fix them, and then at 6 weeks take the screw out, leave the rope in, and off they go. So they get going a bit quicker now. Ones that look like this don't do quite so well. This was a 60-something-year-old lady who's actually the wife of an orthopedic surgeon in town, who fell off a horse and has completely crushed the front of her tibia here. There's very little you can do with that other than bone graft it. I tend to fix these with little tiny plates, and then they get a spanning frame. And the frame essentially neutralizes any compressive load across this fracture. And they keep the frame for about 3 months and then take it off and everything's healed. But it's really difficult to deal with osteoporotic fractures around the ankle when all this bone is just dust. And that's where the hindfoot now comes in if they're older. So the elderly patient, especially the one with poor soft tissue, so the big swollen ankle that's already got the sort of cellulitis looking skin or the dark sort of discolored skin, very swollen. It's a really nice option to put a hindfoot nail in because it's percutaneous surgery and it allows them to get up straight away. So this is a case from this week at the RA, not too bad a fracture, but in a patient who was in mid-80s, poor specimen, really bad skin. And so you simply put a percutaneous nail up from below and it spans the ankle. It makes it stiff, they can't move it, but they can get up and walk the next day, and it's all done through a couple of 1 centimeter incisions, and they don't need a boot or a plaster. So for that real elderly group that otherwise are a nightmare to manage and you can't fix them in normal fashion because they'll get infected and fall apart, this is actually a nice option for them, and that's relatively new. But I think with ankles overall, there's no rush. No ankle ever fell apart in the first 10 days. And so it's absolutely reasonable just to elevate ice, backslide or a boot, come back in a few days, have an x-ray in a week, and then make a decision. For the ones that we're not sure of, there's really no rush. As long as they get surgery before 2 weeks, they do fine. anyway. Now, this group are really, really tricky. So there's the sprain that doesn't resolve. So they come in with their swollen ankle, they've had their accident, you send them for an x-ray and the report comes back, says no fracture. And so you reassure them and say, yeah, you sprained your ankle, you can have a boot or not, and see how you get on. And then they come back a week, 2 weeks, 4 weeks, 6 weeks later, and it's still swollen and it's still sore. What do you do with them? And they're really difficult. And for us in hospital, it's easy. They all get an MRI scan because that's what we do. But that's because we can do it and it's very available. I think in primary care, the question is, how soon do you have to worry? And I think the biggest issue is people don't understand if you get a severe ankle sprain, it is going to take at least 6 weeks to settle down. And so when they come back at 2 weeks and 3 weeks and they're still sore and swollen, the answer probably is, well, it is what it is, give it time. And I don't worry about this group until at least 6 weeks. And part of the reason for that is that if they're not fractured, then any of the issues that they've got don't have to be addressed as an urgency anyway. So it doesn't matter if you wait 6 weeks before you make a diagnosis, and 90% of them will have got better by 6 weeks. So you can sit tight, reassure them, ice, elevation, anti-inflammatories, a boot or an ankle sort of support, bit of physio, and then see how they go. The ones that don't do so well, often you can pick them by the injury mechanism. So if they've had a high energy injury, they may have had previous sprains. And the one that looks a bit like this, it looks like it's had a bad injury. It's swollen, it's bruised. Maybe you can sort of pick them slightly to say, all right, I think this might be a bit more than just a bit of a sprain. But I think 3 to 6 weeks and then consider an MRI scan after that. This is a really typical MRI scan. So there's fluid everywhere. There's an effusion in the joint. There's fluid out the back. There's fluid around the tendons. There's fluid here. There's a rupture of this ligament here. And there's just bits of badness all over the ankle without any one thing that says, this is the problem, this is the solution. And you often get a report back like this that says recent inversion injury, high-grade partial tear of one ligament, a mild partial tear of that one, a sprain of this ligament, a sprain of that ligament. And I think so long as all the words are partial or sprain and nothing says complete rupture, then the ankle is safe and you can treat it non-operatively and it doesn't need anything other than time and physio. The time to worry is if you get an MRI report back that says either there is a rupture, a complete rupture of anything other than perhaps the ATFL. So any sort of complete rupture of the PTFL or the calcaneal fibular ligament, any osteochondral lesions, a deltoid rupture, the sort of the words that say complete basically is worrying. If it says partial, it's not too bad. But that group I think need referring. An ankle effusion is pretty standard on almost any MRI scan after an injury. So now this is an osteochondral lesion, just because we just touched on it, which is a top corner of the talus, sometimes gets knocked off in these injuries. This one you can see on the X-ray and the CT scan. More commonly you can't, and it's an MRI diagnosis. But a small group of ankle sprains that don't settle will have an osteochondral lesion. If they do, it doesn't matter whether you've done anything about it day 1 or week 6. So you pick it up on the MRI scan at week 6 and refer them, and they probably will get an ankle scope to have a look at it and maybe drill it. But there's no rush. So I think the role of an MRI scan in this group of sprains that don't resolve is firstly to make a diagnosis. And so you may see an osteochondral lesion, syndesmotic injury, a complete ligament injury, or occasionally tendon injuries or pulley injuries. So sometimes the peroneal tendons that run, they're held in place by a retinaculum. If that ruptures, the tendon dislocates forwards and backwards. Occasionally you'll pick those up, in which case they get referred. Most commonly, it's a partial injury and you can reassure the patient that everything's fine. It's just going to take longer to settle. I think if you get a report back that says everything looks all right, but there's a lot of inflammation around a specific structure like a peroneal tendon or TIBAN, it's not unreasonable for them to have a local cortisone injection under ultrasound to try and address that. So the MR might pick that up, but I think typically the MR is for reassurance that there's nothing terrible going on.
Just before we move on, we've had a good question from Sean. How good are ultrasounds compared to the MRI if you can't access MRIs?
Yeah, it depends on who does the ultrasound. That's the problem. Yeah. I mean, MR depends on who reports it as well. Yeah. My experience is that the MR reports tend to be better than the ultrasonographers, And I think partly because the MR is reported by a consultant radiologist, whereas the ultrasound is typically done by a radiographer. So there's a different level of skill there. But ultrasound, clearly, if it picks something up, it's good. The trouble is, I'm not sure I trust a negative ultrasound as much as I trust a negative MRI scan. Yeah. So moving on, jumping around to a different part of the body, clavicle fractures. The clavicle fractures in adults are different to children. In a child, they all heal. They do brilliantly. In adults, that's not necessarily the case. And we're now, as a group, orthopods, much more aggressive at fixing clavicle fractures than we ever used to be. And the reason we fix them is that if the clavicle shortens, then your shoulder protracts, it comes forwards, and that actually seems to affect your shoulder function. So if they're very short, they get fixed. If there's a butterfly section in the middle, then they tend to have a higher risk of non-union. But more importantly, if you fix them, they get back to normal in 10 days, and they love it. And this group of patients, they come in and they're sore, they got their arm in a sling, they're really struggling. They have an operation that takes 25 minutes, and the next day they feel better. And so the biggest reason we fix these now is just because patients expect to get back to normal much quicker. So fractures like this that we would always just have put in a sling and say, go away and put up with it, it'll do fine. Nearly all of these seem to get fixed these days, and they just get a little plate that sits on the top. And instead of getting a bump that sits there for the rest of their life, they get a scar that sits there for the rest of their life. A fair number of them have the plate taken back out because the seatbelt comes across here if it's the right side or the left side there. If they're on the passenger side, they don't like that. But it's a simple thing to do. This is just one that I put in for interest. This is a 70-odd-year-old chap who had this fracture around 5 months ago that was treated non-operatively because he had rib fractures and a pneumothorax. He came back in this week to the Royal Adelaide having fallen and refractured it and gave himself an axillary artery injury. You can see on his CTA, his axillary artery has a big gap in it here, which is really, really rare. And so he had his embolectomy and a stent put in. You can see the stent runs from here to here. And then they very kindly handed him over to us and said, can you fix his clavicle now, please? Which was slightly hairy because you could actually feel the stent underneath there. But vascular injury is really, really rare with them. Humeral shaft fractures just heading down the arm, absolutely the same. We're definitely much more aggressive. And the single reason we fix all of these is if I had this injury, I would have it fixed straight away because it hurts a lot and you're out of action for 3 months as a minimum. Whereas you have an operation and a plate put on it, 10 days later, your arm is functioning normally. And so it's nothing to do with union and it's nothing to do with the eventual outcome. It's to do with the fact that you don't want 3 months of pain and disability and then the stiff shoulder that goes with it and the stiff elbow that goes with it. You just have an operation and fix it and it gets it over and done with. And the old debate of nail versus ORIF doesn't really exist. They all get plated. Humeral nails don't really have very much of a place because they cause trouble at the shoulder and they have much higher reoperation rate to take them out. So humeral shaft fractures, something like this comes into the RA, unless there's a very good reason not to, they pretty much all get plated. And it's a simple operation with a low complication rate and a good union rate. This chap, this is an x-ray that's, I think he was 8 weeks down the line by then. He's already starting to heal and functioning back to normal. Arm wrestlers, we see a few of those. I don't know why people want to arm wrestle to the point where they break their arm. You've never won at that stage. And so it's just another little group of patients that we end up operating on. Fifth metatarsal fractures, these have gone the opposite way. So when I was training, there was always a big debate about these. We used to talk about, is it displaced or not? Is it into the joint or not? And there was always this big debate about, will they go on to non-union? Should we be fixing them? And it appears that all the evidence now swings towards the fact that actually they nearly all do fine with nothing. And so I can't remember the last time I saw one of these get operated on. And the treatment for these is purely just symptomatic. So if they can walk around in their thongs, that's fine. If they need a boot, that's fine. This is a Darko shoe, which is a funny shoe with a big heel that just makes you heel walk, that's fine. You can do what you like with them. 99% of them will go on to heal and have no trouble whatsoever. Now, the 1% that go on to non-union then get an operation, but the results of that surgery are just as good as had they had it on day one. And so to save the 99 having an operation, we just ignore this fracture unless it causes trouble, which is really rare. Wrist fractures, I don't know why I'm going up and down the body, but I am. I think to keep my interest as well as yours. So wrist fractures, what's changed there? First of all, KYs. KYs seem to have disappeared completely. When I was training and a relatively new consultant, we KY'd every wrist that came into the hospital. I think. Whereas now they just seem to have disappeared. And I think the biggest reason for that is that if you're going to have an operation to fix a fracture, there's no point doing it in a way that you then need to put them in a plaster anyway. And so all of them, if they get fixed, get a plate and screws so that they then don't need a fracture and they can get going much faster. And so it's the same sort of operation. It takes roughly the same time to put a plate on it. So this kind of fracture that years ago we would have just put 2 KYs in the back of here and 1 in the styloid and then put them in a plaster for 5 weeks. Now they get a plate done to a volar approach. It takes 35 minutes to do, and then you don't put them in a plaster at all and off they go. So I think functionally this is much better. And again, today's patients don't want to wait. They don't want to have 6 weeks in plaster and then 6 weeks of physio. They want an operation today that gets them back to whatever they want to do tomorrow, whether that's work or hobbies or video games, whatever it is they want to do. This is really sort of not rare. I'm not going to say it's common, but it's certainly not rare, which is a triquetral avulsion fracture. So this is the patient who falls over, injures their wrist, they come and you think it's a fracture, you get an x-ray and the x-ray report either says there's nothing going on, or if they pick it up, say there's a flake fracture on the back of the wrist. And it represents a ligament avulsion, and it really is like a sprain, but it's just a bit worse. I think it sits on the spectrum between a fracture and a sprain. It doesn't need anything doing other than symptomatic treatment, and it doesn't represent a ligament injury that's going to lead to wrist instability. And it's not like a scapholunate rupture. It's actually just one of the dorsal ligaments that's just pulled off. And so the management of this, again, is symptomatic and typically is a wrist splint for 2 or 3 weeks until the pain settles and then get them going. But I see a few of these that get referred every year. And it's always slightly worse than a sprain and then more worrying, but yet the x-ray doesn't show a decent fracture and everyone gets very sort of upset about it. But it's just a case of reassuring the patient that yes, it's a fracture, but it doesn't behave like a fracture. It's really a sprain, and they do absolutely fine. There doesn't appear to be any long-term complications from that. Scaphoid fracture is a bit different. An x-ray like this that shows a scaphoid fracture is easy, because you can see it and it's a mil or 2 displaced. And the sort of rule is that if you can see the fracture on the x-ray, then it's displaced enough that it probably needs fixing. And I think we fix a lot of these because the union rate is higher if we do that. If they displace any further, then the avascular necrosis rate at that proximal end goes up. So if I saw this x-ray, I would say that needs fixing. Sadly, that's not the common one. The common one is this one where the x-ray shows nothing. And on this one, you can see it on the MRI scan, but you can't see it on the x-ray. And the wrist fracture patient who comes in, they've fallen over, they're sore in their anatomic snuff box, they're presenting as if they've got a fracture, but yet the x-ray is normal, or a difficult group. And it's a question of who do you immobilize, who do you not? Do you get an MRI scan on everybody? The one thing I would say is that having been an orthopod for quite a long time, 15, 16 years, and having worked in ED for at least a year, I don't remember ever seeing a scaphoid fracture that I didn't think was going to be a fracture. So the patient who just slips over and sticks their hand out and it didn't hurt at the time, but the next day it was a bit sore, and then they come to you and they're quite sore, they've got a sprain, they haven't got a scaphoid fracture. To fracture your scaphoid, you've really got to do something to it. It's a proper injury, and they give you a history that you think, they might have broken that, and you look at their wrist and it's swollen and it looks sore, and you think, that might be broken. Then if they're sore in the snuff box and their x-ray looks normal, I would say that might be a scaphoid fracture. Let's have a plaster for 2 weeks and re-x-ray it. Whereas the one who comes in and you think, well, you haven't really done anything to that, it's probably just a sprain, it looks pretty normal, you're still there and your x-ray is normal, I would say have a wrist splint, go away and use it. We'll still x-ray you in 2 weeks to see again if you want to, but I'm much less worried about that. I don't remember ever being surprised by someone with a really low energy injury ending up with a scaphoid fracture. I think you know that's what they've got. But if you don't, then immobilize them for 2 weeks and re-x-ray them. And then I think if they're If their X-ray is still normal at 2 weeks and they're a bit sore in there, it's almost certainly safe just to leave them alone. If their X-ray is normal and they're very sore, then I would get an MRI scan, and you pick it up on the MR all the time. But I reckon the history gives you everything for scaphoid fractures. Finger fractures, these are nearly the sort of distal phalanx type things. These are nearly always crash injuries. And for me, these are the key questions. So is it open or closed? Because if it's open, they probably need a bit of a wash and some antibiotics. But unless you can see the bone and it's completely trashed, they don't need much else. Is the nail going to survive? So if the nail is badly damaged, then that's an issue. If the nail bed is damaged at the base, and if the nail's popped out, then that might need something doing. But if it's closed and the nail looks all right, and they haven't got a big subungual hematoma that you need to make a little hole in for symptomatic reasons, then this group you can pretty much ignore. Give them a little plastic sort of splint for the end of the finger, analgesia, tell them it'll get better in 2 or 3 weeks, and they're fine. If it's split, but there's no bone sticking out and the nail's okay, then exactly the same. I'd probably give them some oral antibiotics for a few days, put a splint and off they go. The only ones that really matter are the ones where the bone is visible or obviously involved, or the nail is hanging off, or the nail, there's a big crash injury at the base of the nail where the nail bed is, then they're a bit different. But that's not that common, and a lot of these are relatively straightforward. This is different. If you see this on an X-ray report, this is an avulsion fracture at the base of the distal phalanx rather than the tip. And this is the slip of the extensor tendon that's pulled off. And so that needs putting back on, otherwise they'll get a flexion deformity and the sort of swan neck deformity there. But that's a distal phalanx, but it's not a tuft fracture. And then I think finally on the hand, metacarpal fractures, 2 sorts that we see commonly. One is the punch injury, the 5th metacarpal fracture. Most of those tend to get not so pretty much ignored, partly because of the type of people who have them and the way they did it. And if you fix them and put them back, they just come back next year with the same thing again. But in reality, they all look bent. But if you x-ray them before they broke, they look bent then too. It's a bent bone. And so you can certainly accept at least 45 and probably 60 degrees of flexion at that joint. They get a little finger drop, so it sits a little bit like that. And then slowly over the next 3 to 6 months, it comes up as the extensor tendon just takes up the slack. So you might warn them that they'll look a bit like that, but it'll come back up. But functionally, the hand works perfectly well. If they're completely off, then it needs referring and fixing. Metacarpal fractures is all about rotation. If they're lined up, the fingers look straight, and when they flex, they all point roughly at the base of the thumb, which is where they're supposed to point, then that's fine. If when they start to make a fist, the finger's coming across here or across there, then it's rotated, then it needs something doing. I reckon if it's one metacarpal, it's relatively uncommon for there to be too much trouble because they're all linked together. But as soon as you get 2, there's a lot more movement there. And so they're a bit more tricky to assess as well because they tend to be sore. Now I'm a pelvic trauma surgeon, so I can't not talk a little bit about fractures around the pelvis and fragility fractures. I obviously see a lot of these, so they're common in my world, probably not so common in yours, but there is some crossover. So neck and femur fractures, Raymize, geriatric acetabular fractures, staple fractures, insufficiency fractures are on the up. In London, I think the population in the UK is different to here. They're older and more osteoporotic. We see a lot of insufficiency fractures. We don't see so many here, but I think it might be coming in a few years. Not much has changed in the world of neck and femur fractures, other than we're much quicker at getting into theatre now. The single exception to that is people on sort of NOACs. The novel anticoagulants are an absolute pain in the backside for us. So the NOF that comes in, they're on Xarelto, they have to wait their 48 hours for surgery, and it's really poor for them because they just lie there in bed waiting for that to wear off. The biggest reason for that is anesthetics, that they don't want to do a spinal with it. From a surgical point of view, it actually doesn't seem to make much difference whether they're on NOACs or not. But at the moment, we're stuck with that until we have some evidence to say that it's safe to carry on day 1. Hemiarthroplasties, there is a trend which is starting to change the surgical approach. So I do all of my, or not all, 90% of my hips, my primary total hips, to a direct anterior approach. The reason for that is that I believe it gives them a better early recovery. You do a lot less muscle damage, and the evidence in the literature suggests that they get going quicker. And that first, especially the first 2 weeks after surgery, they have less pain, they have quicker mobility, and they're much happier. Now, if you're having a hip replacement, that's probably important a little bit, but it's not anything like as important as if you've got a broken hip and you're having hemiarthroplasty. If ever there was a group of patients who need to get out of bed tomorrow after their surgery, it's the hemi, not the 65-year-old fit hip replacement who frankly can spend a week on crutches if he has to. And so there is a vogue for moving towards direct anterior approach for hemiarthroplasties rather than for total hip replacements. The biggest downside to a direct anterior approach for totals is the fracture risk is higher, but that relates to using an uncemented stem. And for a hemiarthroplasty, you always use a cemented stem and a cemented bipolar. And so that risk is gone. And so we're just about to start a prospective randomized study at the RA with 300 patients getting randomized between the two approaches, just to show what the literature sort of shows that it's safe, but it doesn't prove that it's better. So that's what we're hoping to do. Acetabular fractures in the elderly, it's now become pretty routine to fix the fracture and do a hip replacement at the same time. So they just get out of bed fully weight bearing the next day. We published our series of that quite a long time ago now, 7 or 8 years ago in the UK. And the biggest thing that surprised me was this: the 1-year mortality of elderly acetabular fractures is only 10%. It's not like a NOF. This is a different injury. They're a different group of patients. And when we looked at the data later, the 4-year mortality is about approaching what the 1-year mortality of a NOF is. So the acetabular fracture in the 85-year-old is different to the neck and femur fracture. And more now we fix them and just give them a hip replacement and get them out of bed straight away. So that led us to start looking at pelvic fractures and saying, well, what about the pubic ramus fracture, the old deer that falls over and hurts herself there and can't get out of bed for the next 3 weeks? Should we be fixing them? And actually looking at the literature, this was just published a couple of months ago, there is consistent evidence in the literature that fixing rami fractures significantly improves their pain. There's evidence now, this is just not quite out yet, that the 1-year mortality if you fix them is no different if you don't fix them. So it doesn't seem to be a big risk factor. And you can do it all percutaneously. So again, this is another study that we're looking to do with orthogeries. And this is something that I think over the next few years, you'll see patients coming back to you who've had a simple ramus fracture that in days gone by would have just spent a couple of weeks in hospital. Now they're going to get an operation, which is a percutaneous operation. They'll get discharged 3 days later and they'll be much better. This is a great example. This is Sister Mary, who came into hospital about 3 months ago, fell over, couldn't get out of bed, got referred to me about 2 days later, still not able to get out of bed. And on her x-ray, she's got a ramus fracture here. And there's a little dink up here that looks a bit suspicious and a bit of stuff here, but nothing too bad. On a CT scan, we can see a ramus fracture down here. And again, this fracture line, which does come down here, these are often occult and they get missed because we don't look for them. And I think rami fractures, there's a group of them who just get out of bed and go. And there's a group of them who really don't. And this is that group where it's not actually a ramus fracture. It's a ramus fracture plus a posterior fracture. They're much worse. And here you can see the rami fracture there. So this got an operation and we basically littered her with screws. So you put screws up the superior ramus, across into the sacrum, across the ilium at the back, and across through the pelvis from front to back. So that her post-op x-ray looks like this. But this takes about 40 minutes to do. It's on average about 10 minutes per screw. Each screw goes in through a 1 centimeter incision, so there's virtually no blood loss. And then she was out of bed the next day. And then she's healed by 2 months later. So this is definitely new in it, and I'm certain that it improves patients' early mobility and definitely decreases their pain after these fractures. This is a bit more common, I think. This is a patient who presented with just back pain, nothing else, had a CT, didn't really show anything, had an MRI scan. An MRI scan shows a big white area in the sacrum on one side. This was in June. Told, yeah, it may or may not be a fracture. It doesn't look as if it's sinister. Let's just see what happens. Then she developed pain on the opposite side. So she has another MRI scan, and now she's got, these are fatigue fractures on both sides. So this is just her bone failing for no obvious reason. She then got referred to me in August, and by August, she'd got fractures starting at the front as well. So she gets a percutaneous operation, again, 45 minutes, 4 screws, And all of these fractures go on to heal. So this is becoming much, much more common as we're better at it and as we pick up the indications for doing it. These sort of insufficiency fractures, I think in London we see this a lot. I think it's coming here as well. And it brings us on to bone health. All of these sort of patients that are elderly that have their injuries, bone health is always an issue. I think we as orthopedic surgeons are particularly poor at doing anything about it. And part of that is because the communication from us to primary care is difficult. They get a discharge summary, maybe if you're lucky, that comes from an intern who may or may not know the patient and probably doesn't say anything useful to you. And so some of the time I don't even know if the primary care people looking after these patients even know they've been in a hospital. Clearly the mantra should be ideally treat before, but if not, certainly after the first fracture, they get treated. But it's very multifactorial, and we try and get the physicians and the endocrinologists involved when we can. The big things that I think is less appreciated is the role of vitamin C as well as vitamin D. As orthopods, everyone got very excited when people started seeing papers like this, which is that vitamin C prevents complex regional pain syndrome after fractures. And I think people got excited about this because they were worried that if you didn't give vitamin C to people and then they got CRPS, they could come back and sue you for not giving them vitamin C, which may or may not be true, but if it works, we should probably just give it to them anyway. So most of our wrist fractures and ankle fractures now get vitamin C to stop the risk or lower the risk of CRPS. But actually vitamin C is reasonably important in collagen synthesis, and there is a direct link between low vitamin C levels and osteoporosis. And so I think all the attention seems to go on vitamin D, but actually vitamin C is just as important. And so it probably is something we should be a bit more aware of. Vitamin D, everyone knows about vitamin D and bone health and sort of renal and hepatic pathways. I was slightly surprised by this. So this is quite a nice paper, which was looking at quite a lot of patients, 872 patients, and they measured their vitamin D, and these were all NOFs. And essentially a low vitamin D at admission increased the risk of delirium, as well as new hip fractures and medical readmissions, but not orthopedic complications. I would have thought a new hip fracture was an orthopedic complication. But the bottom line, I think, is that low vitamin D, yes, it affects your bone health and your bone quality, but it also has medical implications for that admission. And so even if their bone quality seems to be okay, if their vitamin D is low, we should probably be trying to up it. The Fosamax fracture is just a curiosity, really. There was a phase where everyone that had any wrist fracture, any thoracic fracture, just got put onto a bisphosphonate. And there are still thousands and thousands of people out there on their bisphosphonates. And most of them, it's fine, and it improves your bone quality. But there's a little group of them who get atypical, atraumatic femoral fractures like this. And they come in and they were just walking along and the femur goes ping. And we know it's the Fosamax fracture because when we x-ray them, they've always got this odd sclerotic beaked appearance to the femur. And when you nail them and they look like this, and then you x-ray them at 6 weeks and 3 months and 6 months, and it still looks exactly like that. And they're really, really hard to get them to heal. And a high number of these end up with this completely excised and proximal femoral replacement because you cannot get A to heal to B. And the guidelines, I think, need to be along the lines that if they're on a bisphosphonate, that they stay on it for however long it is, 5 years, and then they have a holiday. And then at the end of that, you recheck the bone density. And if it's good, they don't need to go back on their bisphosphonate. Because these are always patients who've been on it for years and no one's ever rechecked their bone density. Actually, in this chap who was on it because he had a wrist fracture, we checked his bone density and it was better than normal. And so he didn't need to be on his bisphosphonates that have now given him a major issue. So coming to the end, you'll be pleased to hear. For those in South Australia, I wanted just to highlight a new fracture clinic that has started in the last year or so. It's at Calvary Adelaide Hospital. It's called ADFRAC. And the reason we started this was just that fracture clinic itself, in general, is a service which is really poorly supplied. And I think often with quite a poor experience, patients come back and they say, yeah, I got seen at fracture clinic 5 times but every time I had to wait 4 hours, and I saw a different doctor every time, and no one really knew what they were doing, and I got different answers. And it's a function of the fact that fracture clinics in public are extremely busy. There's a huge number of patients. There's often 4 or 5 doctors, but for 70 or 80 patients. And I don't think we look after the group of the fracture patients particularly well after they've had their initial management. And in private, there's nothing. If patients have their fracture, they can get their operation, but then what about the ones who actually don't need an operation? What do you do with them? What do you do with a proximal humerus fracture who clearly doesn't really need an operation, but they need an orthopedic opinion, and they probably just need someone to monitor their healing? So we set up a fracture clinic at Calvary Adelaide. So the idea is it's a rapid access fracture clinic, several clinics a week. We see adults and children over 10. That's a random number, but it's because once they get over 10, they're roughly the same as adults in terms of their orthopedic management. It's purely consultant delivered. And it feeds into the entire group practice. So ADFRAC, which is the fracture clinic, is part of WOC, the Wakefield Orthopedic Clinic. And so we've got the whole clinic on a sort of doorstep. So if anything comes in that we can't deal with, or we don't have time to deal with, or we need special expertise, and there's the whole clinic there to refer to. And essentially, we see all injuries that are generally sent to fracture clinic, including the non-operative ones. We're very happy to see people who clearly don't need an operation, but just need fracture management. Predominantly, there's 3 of us that are in the clinic, myself, Sam Benvenis and Luke, who are both at Royal Adelaide and work at WOC as well. And essentially, in terms of facilities, we've got 3 clinic rooms and potentially a physio room that we haven't really set up yet, and a clinical room. We do dressings, wound care, sutures. We've got an ultrasound machine for joint injections. We've got splints, boots, the Darko shoes that we saw earlier are all there, but also plasters and plaster removal and application. Now, I'm well aware of the importance of plasters and good waterproof ones. This is my son with his supracondylar fracture of his elbow and a plaster that I put on and took off. That's him with his Montegia fracture dislocation of his elbow and his plaster that I changed and then swapped for a removable one. That's him with his forearm fracture on the other side that I eventually swapped that plaster for a below elbow removable plaster. Thankfully, he hasn't had a fracture for 3 or 4 years now. Unfortunately, I promised him a skateboard if he got 5 years, so he might be back with another one. But in actual fact, having good waterproof plasters is a real bonus, and a lot of patients over the last year have come actually, and the most impressive thing that they like most is actually just having a waterproof plaster on that fits nicely, and if they have issues, they can get back to us. What we don't see, back and spine problems, open lacerations, unless you want to call us and say, look, I've got this patient, it's probably a bit harsh to make them an appointment for tomorrow or the next day. Compartment syndrome, because they're too urgent, and the same with acute neurovascular problems. And walk-in patients with no medical referrals. So although the public can book in, and there's an online booking service, it says on there that they do need a medical referral to get seen. In terms of referral methods, telephone fax, I think the best one is actually this. So if you go online and look at adfrac.com.au, there's a booking section on there, and as a physician, you can click on the section. It takes you to a diary. You can choose a date. It gives you a time, and then if you put just a few details in, it takes a couple of minutes. You can click a referral button, which then generates a referral letter, so you don't necessarily have to do anything else, but it also will email the patient with the date and time, and it emails us with the date and time that's chosen, and then takes it out of the diary. So for out-of-hours referrals, things like that, then this is probably the simplest way, but of course, we're happy to take referrals by any of the routine methods.
Excellent. Thanks so much, Mark. We've got a couple of questions that have just come through. So back to that Fosamax fracture. Does denosumab or Prolia do similar sort of problem?
They don't seem to. It seems to be specific to, I mean, it was at one point thought to be just Fosamax, and then we kind of got on to know it's just the sort of oral bisphosphonates. Yeah, so we don't seem to see them with that.
Yeah. I know with Prolia, the sudden abruption can lead to spontaneous vertebral fractures. Is that something you've commonly seen with the stopping of Prolia, or is that?
No, do you know what? I can't. I've seen it in papers.
Yeah.
I've never seen that clinic.
You've never seen a clinic?
No.
Because they talk about in general practice moving someone from, if you're taking them off poly, you need to put them on a bisphosphonate.
Yeah.
Yeah. So that's interesting
I
that
don't
you've
know.
never seen it.
I've never seen it. I mean, whether it happens and it just gets managed as an outpatient and never crosses a barrels, I don't know. But I've never seen it, and I've never met anyone who said they've had it.
Yeah. And that Fosamax fracture of the femur. Do you ever get humeral Fosamax fractures or?
For some reason, it's always femoral.
Always femoral.
Really odd. It's always femoral, and it's always that upper third to sort of mid third, and nothing else. It's really odd.
Okay.
It must be something to do with the local blood supply to the bone, that it just seems to affect it in that area. And I don't know. I don't think anyone knows why.
It'd be really good. It's something I've never seen is really good recommendations around those osteoporosis treatment holidays. Yeah, I've never seen. Maybe I haven't. Maybe it's out there. I'm just not aware of it. But I've never seen really good guidelines as to what you need to check, how often, and how to have the holiday, how long to have the holiday for.
Yeah.
It's not. The endocrinologists are not sharing that with us.
Yeah.
Probably because they don't agree with each other.
And I've got a feeling they break it up into two groups: those patients that have had fractures previous and are osteoporotic, and those that haven't. And if they haven't had a fracture previous, I think they go Fosamax for 5 years. But if they had a fracture previous, then I think they're supposed to stay on it longer.
Okay.
But
So you've seen guidelines.
well, they're the current ones that I read recently. But, any other questions, guys? Yeah, Sean. Mark just read your question about maybe we should question his parenting.
In my defense, as an orthopedic surgeon, I was clearly not there for any of it because I was too busy at work.
Yeah. And fractures to both arms, so I figured that's accidental.
I've told my wife to go for the fleshy bit. She doesn't listen.
Any other questions for a trauma surgeon, guys? Just put them through or turn on your mic, whatever you want to do.
Sleep.
It's okay. No, you're welcome. I've actually referred to AdFrac a couple of times. Using that website is actually very straightforward. You do have to put in your address and your provider number and a few details. Appointments are up, pretty frequently. I got mine within 24 hours, sometimes same day. So, really good service. Definitely in South Australia, have a look at it. Yeah. No more questions. Role of CT for limb fractures when X-ray unhelpful.
All right. Well, it depends what you mean by unhelpful. Whether you mean it doesn't show a fracture or.
Yeah, so I think he means you've done an X-ray. The X-ray's clear. They've got ongoing symptoms. Would you consider a CT rather than
when you can't get an MRI?
When you can't get an MRI.
Yeah. And for fractures, a CT is almost always at least as good as an MRI. The rare times that it's not is occasionally. I think the data around proximal femoral fractures, so hip fractures, is that MRI is a couple of % better. And for scaphoid fractures, it's a little bit better, where you're looking for the edema rather than any change in the cortical or cancellous outlines. But the vast majority of fractures you will see on a CT scan. And so I think if you're really suspicious and the X-ray is normal, a CT is absolutely a sensible place to start. Yeah, that'd be good. Yeah, I mean, at the moment, frankly, at the RA, it's almost impossible to get through ED without a CT scan, regardless of whether your X-ray shows a fracture. And so they're certainly very, very common.
Yeah. And I know with the MRI referral for the scaphoid, if you've done an X-ray and there's no fracture shown on the X-ray, you then can get a Medicare rebated MRI. So prior to having that first X-ray, you can't jump straight to MRI. But if the initial X-ray is normal, then and it's still tender, yet they qualify for an MRI through Medicare.
After a certain time frame?
No. Just ongoing clinical suspicion.
And it's a tough one, that, isn't it? Because you kind of think, one way to come at that is to say, right, they have an X-ray. If the X-ray is normal and you're suspicious, just do an MRI scan. Because if the MR is normal, they haven't got a scaphoid fracture. And the MR doesn't change after 2 weeks like the X-ray does. The MR will show it from day one. But equally, you don't want to be MRIing every wrist that comes through and shows a bit of tenderness.
Yeah.
And so
And it depends on access. Like
Yeah.
often you ring up the MRI and they say, oh yeah, we can do that in 10 days.
Yeah, exactly.
Well, in which case you may as well wait in 2 weeks
Yeah,
and see if it's still tender.
yeah, I agree.
So it really just depends on access in your areas. Helen's asked a question about how widespread surgical fixation of pubic rami fractures is.
So at the moment, it's probably certainly in South Australia, it's only done at Bra. I know that the guys in Melbourne, so Andy Bucknell and his team in Melbourne are fixing quite a few of them. Joe Isaacs is in Sydney, and I think Rowan Brunello up in Brisbane is also fixing some. So it's one of those things that's just starting to permeate out. The problem at the moment is that if you start fixing rami fractures, all your colleagues just say, well, what are you doing that for? That's pointless. And you start getting a little bit of flack from your colleagues because there's no firm evidence that says it's making them better. Now, we all know it is, and we've all done it. And you see the patient who cannot get out of bed and you fix them, and the next day they're up walking.
Yeah.
So we know it works, but there's no evidence for it yet.
Yeah.
We can show it's safe, but not that it's truly useful for them. And so that's the data that we need. So that's what we want to do.
Yeah. Yep. Excellent. Any more questions, guys? If not, we'll bring the meeting to an end.
My daughter should be very pleased I'll put that.
Okay, thanks for joining, everyone. We'll post about our next grand round soon. See ya.
Thank you.
Thanks, Mark.
Thanks, Mark.